Good afternoon, network, and welcome to today's session where we are having an echo session on tuberculosis. Very, very exciting topic for today, slightly different from what we have been doing in the previous sessions. Today, we're going to be looking at research in tuberculosis. We'll look at the mortality survey that was done by the National TB and Leprosy Program. We'll get some highlights from that survey and draw some lessons that we can use in current practice, as well as to prevent future mortalities. As you know, the TB program is aiming to reduce mortalities to less than 5% of everyone that has been notified of tuberculosis. But you may agree with me that as Zambia, we're very ambitious. We actually don't want anyone to die from tuberculosis. And so in this session, we'll get some insights on what was discovered in the survey that was done in 2019. And with me in the hub today, we have Dr. Patrick Lungu. He's going to be our didactic presenter for today's session. He'll take us through the topic for the day. Allow me to ask Dr. Lungu to just introduce himself and give us a little bit about some information about himself, what he does, especially in the sphere of tuberculosis. Then we'll get straight into the didactic presentation.
Thank you so much, Dr. Singini. I would like also to firstly express my sincere appreciation to the TB program for inviting me to share insight around the findings of the TB mortality study that was conducted by the Ministry of Health, working together with USAID, and in particular, Eradicate TB. As introduced by Dr. Singini, I'm Dr. Lungu Patrick, currently working with East Central and Southern Africa as a manager responsible for health systems and capacity development. And I also support a number of TB initiatives within EXA. So I'm happy to be here and glad that this platform has been sustained, and hope we will have a lot of interactions. Thank you.
Thank you so much, Dr. Lungu. To support Dr. Lungu, we'll have a number of subject matter experts that will join us. Among them is Dr. Tishala Chavala, who is a consultant pediatrician and a researcher in the TB space. We will also have Dr. Monde Myoyeta from CIDERS. We expect to have Dr. Lunga Ziko from Project Concern Zambia. We're also expecting to have Dr. Mary Kaguje from CIDERS. I can see we already have Dr. Chitalu Chanda, an ID physician, on the call. So we will be calling upon the experts at some point also to share some insights on whatever is going to be discussed today. So at this point, allow me to then hand over to Dr. Lungu to take us through the didactic for today.
Yeah, thank you so much, Dr. Singini, and good afternoon, everyone. Before we dive into the presentation, let me qualify that I'm just a representative of the great men and women that conducted this noble study. So some of them are here joined, so I'm happy to represent the team, and they will also participate in unpacking this particular study. So indeed, Zambia conducted a TB mortality study. I would like to say that probably this, if my memory serves me correct, this was the first and extensive study that has explored the issues to do with mortality related to TB in Zambia, and I hope that there will be subsequent studies to evaluate and explore issues to do with TB mortality. So I will represent a team, and I would like just to start by also sharing a bit of insight around the TB response in Zambia as reported by the WHO. Zambia is still one of the 30 high-burden TB countries in the world, with a TB incidence of 295 per 100,000. This is according to the 2022 statistics reported in 2023. This translates into at least 59,000 TB cases that are recorded annually. And one of the most pleasing things about the TB response in Zambia is that the TB case finding has actually shifted in the positive trajectory, where we have continued also to see a continued decline in TB incidence. We've continued to see an increase, sustained increase in TB notifications, even during the COVID period, which most countries recorded a decline in TB case notifications. But also more pleasing is what we see here, where we're seeing HIV negative TB-related mortality taking a deep dive, an accelerated decline between 2020 getting into 2022. So this is as a result of the enhanced case finding efforts, but also I want to share that this is also a similar picture with people living with HIV, but we see a much more steeper decline in HIV negative TB patients. But also of great interest to us is that the TB case fatality rate for Zambia is at 9%. If we are to compare the TB case fatality rate for Zambia with that of the global village, Zambia is doing far much better. The global village TB case fatality rate is at 15%, and that of the entire Africa is at 18%. But of course, Zambia is racing towards achieving the WHO target, which is at least 95% people who are diagnosed with TB living or being successfully treated. That in itself means that the case fatality ratio would be at least 5%. So indeed, of course, while Zambia is doing very well, but has not yet hit the WHO benchmark of a case fatality ratio of at least less than 5%. So I think just to put everything into perspective, these are the milestones that Zambia is trying to achieve, and also the set targets that Zambia has pledged to achieve alongside other countries in the world under the NTB strategy. So of interest to us is one of the indicators that is being tracked globally, which is the reduction in number of TB deaths compared to 2015, and of which there are already some milestones that will evaluate where Zambia is, the 2020 milestones, the 2025 milestones, which is just a few months from now, and then also the SDG milestone or target of 2030 and that of 2035, which is 95% reduction when compared to the 2015 as a base. I will not dive into the other indicators of interest, but for now, I think we'll focus on this indicator of great interest. So I think it's pleasing to report and to share that Zambia is one of the few countries in the world that achieved the 2020 milestone, which was a 35% reduction in TB mortality as compared to 2015. So I think kudos to the entire TB team, partners, and the TB program from the Ministry of Health for achieving this momentous milestone. And indeed, Zambia is poised to achieve the 2025 milestone from what I see, and hopefully Zambia will still achieve the 2030 milestones in this regard with reduction of TB mortality. But of course, for us to achieve that as a country, we have to actually double up some efforts and also reflect as where we are with regard to TB mortality. And I think this study serves its purpose in actually providing insight into the drivers of TB-related mortality and what are the characteristics of patients that end up dying. So we will look at that, and so that some programmatic and clinical interventions can be put in place to abate TB mortality. So again, congratulations to Zambia for this great milestone attained, and hopefully that the 2025 milestone will equally be attained. So dear colleagues, this is what has brought us here, and I'm happy that the country is interested in the findings of this study. And these are some of the authors that are listed there: Josephat, Lamia, Victoria, Riab, Nancy, Lamek, Mishota, Refort, Sulani, Bimbai, Soka, and Dr. Alwin Meng, and of course, I was part of the team that led this initiative. And of course, there are others who we will acknowledge much later. Just to indicate that in this particular study, we sampled at least over 13,000 files of TB patients that were recorded in the entire year of 2019. And of course, we excluded over 2,000, and what remained in the study and which was analyzed in this particular paper was over 10,000, closer to 11,000 patients. Of course, we excluded those transfers in and those where we were a lot of inconsistencies in terms of data or where outcome was not evaluated, but we were interested in actually determining mortality and other parameters. So to just dive into it, you may already have picked it up that the main objective was to determine the characteristics and causes and time to death for TB patients. And here we looked at mainly in drug-susceptible TB. So this study did not include drug-resistant TB patients and their caregivers. In terms of the specific objectives, we described characteristics of TB patients that died while on TB treatment. So you know that actually this study did not include TB patients that were not on treatment. So the cohort that was restricted was the 2019 cohort, and indeed patients who were on treatment. And the second objective was to determine the time to death. So we needed to know when are the TB patients dying. And this has also some implications on a number of issues which we will discuss. Thirdly, we looked at assessing factors associated with mortality. Fourth, we also looked at what were the actual causes of TB mortality or death in TB patients. Lastly, also, we thought to understand TB patients and caregivers' experience of accessing and receiving care. So from this, I think you pick up that this was a mixed method approach. And we actually did both quantitative and qualitative. And for the quantitative, we used data to analyze the data. And also you realize that we did actually analyze, bring out the descriptive statistics. And also we assessed the hazard ratio using Cox regression. In terms of the qualitative method, we actually used the thematic analysis to actually collect, to analyze the themes and also to analyze that component of the study. I want to also just to qualify that within the qualitative component of the study, we interviewed at least 10 TB survivors and also 10 caregivers of deceased patients, just to get their perspective and insight as what makes one succeed with TB treatment, and also what are some of the factors that lead to TB death, which are not biomedical. So we essentially, I think, just to qualify that this was a mixed method study, quite comprehensive approach. And indeed, as you saw from the sample size, that this was quite a reasonable, adequate sample size for any study of this nature. And you see from the red dots or the red crosses that we visited every province. So the entire country was represented. No part of the country was left out. And in total, we visited 54 health facilities, which included primary healthcare level, secondary level, and also tertiary level hospital, including the mission facilities. And then for the qualitative component, we do not visit every aspect. And you know, for those who are involved in qualitative studies, we will know that it was not warranted. And we visited at least 10 facilities. And within those 10 facilities, we visited the 10 patients. We included the 10 patients as well as the 10 caregivers of deceased TB patients. So indeed, again, quite representative as well in this particular arm. And I want to say that before we conducted this study, we actually wrote a protocol which was subjected to ethical approval by UNZABREC and later on reviewed by NHRA. And for every participant in the study, especially for the qualitative aspects, we got written informed consent. And also just to indicate that all the data within this study could not, we de-identified the data. So essentially, we did not pick up patients' names and anything that would actually identify any particular patient or any particular disease individual, and data was kept highly confidential. So we have the first 4 questions, which are some related to the findings of this study. And the first 4 questions, I would like to Singini to run the first 4 questions. So Singini, over to you.
Thank you so much, Dr. Lungu. And as we go, colleagues, if you have some questions regarding what is being presented, do not hesitate to put your questions in the chat box. And as we get to the plenary, we will look at those. So the first question is, does TB cause sepsis? Does TB cause sepsis? A, yes. B, no. C, do not know. Right? That's the first question. Does TB cause sepsis? A is yes. B is no. C is do not know. Now remember that these 4 questions are anonymous and we are unable to determine what your answer is. And so we encourage everyone to submit the polls. It helps the didactic presenter know what to focus on as he is presenting. Now, as people are polling, allow me to also acknowledge that we have Dr. Chimzizi on the call, one of the subject matter experts that I will call upon at a later time to share some insights on this presentation. All right, so I'll end the poll now. We have over 110 people that have participated, which is very, very good. I wish we could have more people to participate, but in the interest of time, I'll end the poll here and share the result. We see that out of 120 people that have polled, 74% thought A is the correct answer, that TB, yes, TB can cause sepsis, but we still have 18% that thought B, no, was the correct answer, and 8% said they did not know. So thank you so much for sharing your thoughts. I'll hand over back to Dr. Lungu.
Yeah, thank you so much, Singini, and quite intriguing responses that we have gotten. At least 26% either didn't said no or did not know, and I think I'll focus on this particular group. So, dear colleagues, I wish to share with you that TB indeed can cause sepsis, especially in individuals who are severely immunocompromised, such as advanced HIV disease, and individuals, children as well, and also the advanced age group as well. TB can actually cause sepsis. And other individuals with other causes of immunosuppression other than HIV, undernutrition, diabetics can actually develop TB sepsis. So just to share with you a study that was conducted within Zambia, and to some extent, I love this study because it brings a lot of insight to the TB program. And this is a study that was conducted here at the University Teaching Hospital and conducted by our dear colleagues, led by Dr. Mchemwa. And in this study, they found that individuals who presented with sepsis at UTH, over 34% had TB bacteremia. And within that particular cohort, TB mortality, or rather mortality, was over 80% within 48 hours. So this just tells you how aggressive TB sepsis can be. And in most cases, those individuals were actually persons living with HIV. So this was to a very large extent in individuals with advanced HIV disease, which to some extent now with the good ART we don't get, but I think there's still a significant proportion that still present with advanced HIV disease. So, and you will see what we've established in this study. And this study by Mchemwa was done between 2014 and 2016, but published around 2016. And our study is a 2019. So if they found TB sepsis in 2016, we'll see what we found in this study.
Right.
So over to you for the next poll question.
Great, thank you so much. The second poll question reads, should TB treatment be tailor-made to suit clinical presentation? Should TB treatment be tailor-made to suit clinical presentation? Option A says yes, B says no, C is I don't know. I'll repeat the question. Should TB treatment be tailor-made to suit clinical presentation? Option A, yes, it should. B, no, it should not. C, I do not know. There we have it. These are among the most most user-friendly poll questions I've seen in my all these years of doing echo.
Yeah.
And so I expect that the participation will actually be at 100%.
Yeah.
And again, as a reminder, we are unable to see the answer that you chose. So please feel free to participate in the poll by selecting the best answer. I'll repeat the question. Should TB treatment be tailor-made to suit a clinical presentation? A, yes. B, no. C, do not know.
Yes, Singini, I chose these questions. I'm sure you've seen that these are simple questions.
Very simple.
But with huge implications.
Exactly.
As simple as they are, they have huge ramifications.
Right.
And we'll discuss why.
Exactly. And, it's actually very interesting to see how the polling pattern has increased so far, which just shows that there's really a lot that we can discuss that can emanate from these poll questions. Right. It's been a minute. It's actually been 2 minutes. I will end the poll at this juncture and share the results. So we have 59% out of 138 people who participated thought yes is the correct answer. And we had 36% of the participants who polled saying no as the correct answer. And 4% of the respondents said they did not know, which is good response as well. And so I'll stop sharing the results again and circle back to the didactic.
Yeah, thank you so much. So we'll not answer or give responses to this particular poll questions, but I would like us to circle back to it later in the presentation or discussion. So the third poll question.
Right. The third poll question says, should we employ multidisciplinary approach to TB management? Should we employ multidisciplinary approach to TB management? There you have it, network. The poll has been launched. Please choose the best answer from these 3 poll questions. All right, the responses are pouring in like a wildfire, and it's very, very encouraging for us on this end to see your participation. And thank you so much. Thank you so much for your responses. Oh, I can see the responses pouring in. We are currently at 134 participants out of 208, which is very impressive. I have a feeling we are going to reach 100% on this one. All right, I'll give it a few more seconds as we receive more polls. And just as a reminder to those that have just joined in, today we're looking at disseminating findings from a TB mortality study that was done by the National TB and Leprosy Program with support from ETB. Which involved getting qualitative and quantitative data from all the provinces in the country. So the didactic presenter is Dr. Patrick Nungu, who is a TB expert, who has worked in the TB circles for so many years, and many of us have learned from him. Right, so I will end the poll at this point. Very, very impressive turn of participation. I'll share the results in a second. So we had a nearly perfect response with people inclined towards A as the correct answer, that yes, we need to employ a multidisciplinary approach to TB management. We had 3% that thought no was the correct answer, and no one said they did not know the answer. So thank you so much for your polls. I'll end the poll here and get back to the presentation.
Yeah, thank you so much, Dr. Singini, and thanks to you all for the responses. So I want just to share with you the patient characteristics that were enrolled in the study, or rather the characteristics of for this study. So as earlier said, that this study was quite representative. Almost all provinces participated with at least 54 facilities taking part. The largest participants actually came from the Copperbelt province with over 1,000 participants. Sorry, Lusaka. Lusaka had the largest participants with 4,000, followed by the Copperbelt. But you can see that almost every other province was well represented, with only 194 within Central Province. So the least represented was Central Province. In terms of the types of TB, all forms were represented within this study. We had the bacteriologically confirmed, we had the clinically diagnosed PTB patients, and also we had a fair share of EPTB, and only about 49 admitting in terms of indication of the type of TB. Then coming to whether the patients were HIV positive as well as on ART. So this particular one is just looking at, for the patients who were living with HIV, how many were on ART. So a good fair share of TB patients had a good exposure to ART, at least 93 points. I would rather say 94% were on ART, and only about 3% we did not define whether they were on ART or not. So we also remember one of the objectives was to look at the time to death. When are the TB patients dying? And I will explain why this is very important. So what we established from this study is that the TB patients, the majority of the TB patients were dying within the first 2 months of treatment. What this means that this has implications. It actually means that TB is being diagnosed late. And then also it means that our chemotherapy for TB is effective. Remember, when one is diagnosed immediately, if they are continuing post 2 months, if they are lower death or no death or hardly any death, that means that post 2 months, the chemotherapy is very effective. And this one, it also suggests that what Zambia is using for drug susceptible TB, patients are responding to it. And the attributing factors to the early mortalities in the phases of treatment, it actually implies late diagnosis. So very advanced TB disease, to the point that even the chemotherapy or the anti-TB treatment can actually not cure the TB because the disease is very, very advanced. And this is why the poll question number 2 is asking us, should we tailor-make the treatment modality to the patient's presentation? Yeah. We will dive into that much later, but indeed we answered this objective, and also the study did establish that the majority of the TB patients are dying in the first 2 months of therapy. And this is where most effort needs to be put in to ensure that the patients, one, is adherent to treatment, and secondly, that they have the full support. This is the most critical stage of any TB patients, be it drug susceptible TB, drug resistant TB as well. So just also to show in terms of the covariance or the factors associated with TB mortality in this particular study, what we established is that advanced age were at a higher risk of dying from TB. As you can see, patients from the age of 55 onwards are at a higher risk of dying from TB. And again, we also looked at, sorry for the bad slide, but what we also looked at the method of diagnosis. What we established is that individuals who were diagnosed by a method other than GeneXpert were at least 1.4 times at risk of dying from TB compared to individuals that were diagnosed by GeneXpert method. Already you know that GeneXpert is able to pick up where there is minute or pulsy bacilli. Yeah. Other methods require higher yield to pick up the bacteria. And also what that means that individuals who are being picked up by other methods other than the GeneXpert have a higher bacterial load. Because if you are to look at microscopy, for example, for microscopy to pick up active TB disease, there has to be a higher colons presented within that sputum, as opposed to the gene expert, and hence what we are observing from this result. And again, also, we see that individuals who were not on ART were 2.4-fold at risk of dying from TB. This in itself just highlights the importance of ART in TB treatment. The issues of multidisciplinary approach, I'm happy that everyone responded yes to that question. So indeed, multidisciplinary approach to TB is of paramount importance. The other aspects is we looked at the care approach, and here we were assessed for the DOT plan. I wish to qualify that in the original report, what we found that individuals who were looked after by their family member had better outcomes. What that then implies is that while we have community-based DOT, facility-based DOT, we should not substitute the role the close family members play. And this in itself implies that we should involve the caregivers who are family members in the care of that patient. That's what this study is informing us. We looked at predictors of mortality, and here we looked at which province had the highest risk of mortality. You will be surprised, and I think this caught us by surprise, that Central Province was one of the highest in terms of TB-related mortality compared to other provinces. What we already knew, what the program knew at that time, that TB mortality was highest in Southern Province, yeah, as well as Eastern Province. And I think even in routine reporting, I'm not so sure about now, but I think at that particular time, Southern Province and Eastern Province had the highest, if not one of the, you can see already by these statistics, 2.6-fold when compared to Lusaka, and that of Mochinga 2.7-fold when compared to that of Lusaka. And in the case of Southern Province, it was 1.9, Western Province, it was 2.6. So this is where the provinces stand, and Copperbelt had the lowest, if not Luapula and Copperbelt had the lowest, together with Northwestern Province. So indeed, in these provinces, there's need for some more concerted effort. In the case for Mochinga, I think the facilities are sparsely distributed, leading to late diagnosis, hence this results. And I think that's a similar case for Central Province and that of Western Province, that the facilities are far apart, and TB patients it's taking them much longer to diagnose TB. And also, if you actually match in terms of the number of gene expert machines within these provinces, you will realize that Mochinga may have one of the lowest, and probably even Central Province. The TB program may need to match, again, I say, especially that one of the findings showed that when an individual is diagnosed using a gene expert, they are less likely to die as opposed by any other diagnostic method. So this is why mortality is distinct by province from what we found from the study. And this in itself starts to point to where more efforts needs to be pushed into by the program to lower mortality, and where targeted efforts needs to be pushed into. We also looked at the level of care in terms of mortality, and what we realized is that, and I think expectedly, the third level hospitals had quite a higher mortality or the risk of mortality as opposed to the primary healthcare level. But I also want to qualify that the mission hospitals were at the same level as the third level hospitals. To some extent, mission hospitals serve or function as referral hospitals. Right. So they equally receive very advanced cases of TB, hence this particular picture. So indeed, what is actually happening is that we are referring critical cases late to where they need to be picked up. If not, advanced TB is being picked up only at tertiary level hospitals. So essentially, what this starts to point is that we need to enhance the clinical skills at the primary healthcare level, where patients first present, so that TB is picked up at the very first point of accessing healthcare. Then with regard to HIV and TB, we see that individuals who are living with HIV were at least twofold at risk of dying from TB as compared to the HIV negative. Similarly, the individuals who had their HIV status are no statistically significant, but we see a twofold increase. Going by the clinical type of TB, we saw that individuals who had clinically diagnosed PTB were 1.7-fold. Also so close, very shocking when you compare it with the bacteriological control. Not so much difference in terms of the risk of mortality, and also both were statistically significant, but also we start to see a much higher risk of mortality in those with extrapulmonary TB. Here's a result which I was talking about, where we saw that relatives to TB, the DOT plan, where the DOT plan was that of a relative, they had at least 40% reduced risk of TB death, itself emphasizing and amplifying that relatives must be involved in the care of the TB patients. And I think it just follows the natural practice. Relatives should not be put aside in the care of the TB patients while we are the experts. Coming to the probable causes of death. So here we looked actually at the individual patient files, and that we had TB experts looking at this. On the left, we looked at the death certificates and what the death certificate indicated, and we matched it against the assigned probable cause by TB specialists and internal medicine specialists, as well as pediatricians who participated in this study. And we see very minor differences. So what it actually tells us that we are assigning the correct cause of death. Yeah. And what this also, it starts to challenge the current normative guidance by WHO that not every TB death is caused by actual TB. Others is caused by other things like superadded pneumonias. Others are caused by aspiration pneumonia. So in itself, we should not, probably for now, I will not say we shouldn't, but I think WHO must look at this data and probably start to consider having clinical indications of cause of death. Mm-hmm. And like to say every TB death is caused by TB, not so related. Remember the first 4 questions we looked at, does TB cause sepsis? Here we are, 18% of TB patients died of sepsis, a very large proportion, followed by disseminated TB, thirdly by end organ damage and PTB, anemia coming fifth, but more interesting as well, TB meningitis featuring. I would like to single out the sequelae of TB as one of the causes. This was most probably in a TB relapse case or a retreatment case. So what we see largely from this is that the largest proportion of TB patients that die, the cause of death is attributable to sepsis and disseminated TB. So we therefore need now to build the critical clinical skills to recognize sepsis, and also in patients presenting with sepsis, we should also expose them to TB tests, because as you see, 18%, if not 19%, of the cause of death in TB patients was TB sepsis. A sizable proportion of the mortality is at end organ damage. And common among them was renal failure, heart failure, liver failure, and some had multiple organ failure. What this then means is that TB is being diagnosed fairly late, and some of this is whenever there's sepsis, there's infection everywhere. So every organ is heavily affected. Hence what we saw from this study. And in itself, this starts to propose and motivate that there has to be multidisciplinary approach and tailor-made approach to clinical management. Unlike PTB is equal to 4 FDC, I think we need to start to move away from that sort of practice and to bring in enhanced clinical approaches for us to end or reduce TB mortality. So again, I think probable cause of death only in HIV individuals. So we we analyzed the data specifically for people living with HIV. And what do we see? TB iris, 18.9%. TB sepsis, 17.5%. End organ damage, 14.6%. Anemia, 12.1%. And PTB, 9.3%. And this is why we're saying that the poor question, should TB treatment or management is based on the clinical presentation. So I think we need to reevaluate our current approaches to TB treatment in individuals with advanced HIV disease to avoid TB iris. As you can see, 18.9% attributable to TB iris, quite high proportion. And again, TB sequelae again being featured among people living with HIV. So some attention needs to be put in this particular area. So in terms of predictors of mortality, we can say that persons with EPTB at 1.7 times the risk of increased risk of mortality when compared to the bacteriologically confirmed individuals. Secondly, mortality hazard ratio for patients diagnosed using methods other than expert increased by 30%. And then fourth, we noted that persons with TB who were co-infected with HIV had a 1.8% or 1.8 times increased risk of mortality as compared to HIV negative individuals. And lastly, in a sub-analysis of persons who were co-infected with HIV, those who were not on ART were 2 times at risk of dying from TB compared to those of who were on ART, itself signifying the importance of good ART management. And again, I will not overemphasize, but rather to emphasize again the issue of multidisciplinary approach. And I think the TB HIV in Zambia, TB and HIV programs have been working hand in hand, and I think this must continue and further be enhanced. So I think just to put it before you in terms of which organ damage did the patients have, the largest proportion had heart failure, and some of these had TB pericarditis, but also you know that TB sepsis can affect the functionality of the heart and leading to heart failure. And some of this also was related to anemia as well. So anemia of chronic illness not being addressed, resulting into heart failure. Then we had acute liver injury, also at least 28%. We also had a significant proportion of both chronic and kidney failure and adrenal insufficiency, at least at 7.5%. So these were the end organ damage that we saw from the TB patients that in this particular study. But also I want now to bring in the perspective that we gained from the caregivers and former TB patients. We'll read the first one and we'll read the second one. So the first one is looking at onset of symptoms. He refused to go to the hospital for treatment for about a year. He feared that he would be tested for HIV because he had a series of girlfriends. So already I think what we pick up from this is that the fear for HIV testing is still there. So more awareness needs to be put in place. So we should not stop raising awareness for HIV testing. Secondly, I used to buy him medicine in Indola, and sometimes I collected herbal medicine in the bush for him. Wow. So you could already start to see that people are seeking unconventional means of care. Herbal medication did not cure TB at all. And instead, they bring about hepatorenal failure, as we saw liver failure accounting for 28% of the end organ damage, and also renal failure, both acute and chronic, at a significant proportion. Help me read the second one.
This one came from a former TB patient from Choma who said, I went to public and private health facilities for about 6 months without improvement. I became desperate and I had to visit my mother in Gwembe so that she could take me to a traditional healer, but immediately suspected that it could be TB. That is how they found TB in sputum. Very interesting account.
Exactly. So already you saw you waited for over 6 months.
Yeah.
But one interesting thing is that he found his mother was an uninformed person who was informed about TB symptoms. So again, let's continue spreading the word around TB, even among non-TB patients, because they can save an individual, as it happened in this particular case, where he thought that his illness was from other causes other than medical. But his mother was quite alert and well-informed, who said, what you have, my son, is TB, and took him to the right. And this particular individual was lucky survived.
Yeah.
The third one.
And so the other account came from Kitwe on the Cocoa Belt. This was from a caregiver and said on the perceived cause of death while on treatment. They thought he drank alcohol whenever he had money. He did not smoke. I suspect that the alcohol he drank, he took whiskey without diluting it. Yeah. He drank it directly without mixing, though he never drank alcohol when he was on treatment.
Yeah, but difficult to rule out. It's most likely that he was taking alcohol while on TB treatment. As you can see, he was a heavy drinker. So indeed, these are some of the areas we need to educate our patients to reduce mortality. Alcohol in itself causes liver damage. And the like. The last one, I do not know even now what caused the death of my daughter, because doctors never explained to me why they stopped TB treatment when she was responding very well.
Yeah.
So I think from this, what we pick up is us as clinicians and nurses, we're not explaining to the patients what is actually happening. And the other thing is that this is perhaps a caution to the clinicians: never stop TB treatment until you have a substitute confirmed working diagnosis. So continue the TB treatment if the patient is responding very well. But another learning point from this is that let's involve the caregivers and the patients themselves, and let's take time as healthcare workers to explain to the TB patients and their families what is happening. Even every step that we make in the management plan or shift, it must be explained. In this particular case, the mortality, sadly so, yet the patient was improving, but we withdrew treatment. It's probable it was an end organ damage, and then TB treatment was withdrawn for fear of further damage to the organs. We don't know, but the underlying point is that whatever the shift in management was not explained. So I think a lesson learned to all of us, that let's take time to explain to the caregiver what is happening to the patients. So I want to say that while we note all these huge lessons and insights, I want to say that this study was highly powered, and although while highly powered, it had some limitations, and I want to highlight some of the limitations. You've seen that we did not talk about the nutritional status and its implications on mortality. Other studies have shown that low BMI correlates to pretty well with mortality. In this particular study, we were limited to evaluate for the implication of nutritional status on mortality due to missing data. Either they had weight, but they didn't have height. So we could not ascertain the BMIs and the like. So this one of the things that I would like to appeal to everyone on this platform is that let's make sure that we weigh the patients, and every month we calculate the BMIs. Right. Get the height, the weight, calculate the BMI. Secondly, we could not ascertain the status of those that died or did not die for patients that were either lost to follow-up. We don't know what happened. So for that particular aspect, we were limited. Thirdly, we did not perform autopsy. Remember, autopsy is a gold standard, so we relied on the experts. So we controlled for this limitation by utilizing experts to evaluate the files. And the experts came from the University Teaching Hospital, Department of Internal Medicine, who thoroughly, and 3 of them at least discussed the file and attributable to the cause. So essentially, we controlled for that by bringing in experts to examine the files that we found. So to a very large extent, this study brings out a lot of insights to us, which is valuable to both clinicians and also to the programs and partners involved in the TB response. And I would like to read them out. Firstly, the TB-related occurs in the first 2 months of diagnosis and treatment initiation, implying late diagnosis. Second, a significant proportion of patients died from disseminated TB and TB sepsis, and also with or without any organ damage. Thirdly, approach to TB management is not distinguished by type of TB in most cases. So there's no tailor-made treatment. Most are receiving the same approach for FTC, and most of them are receiving for FTC orally. Perhaps let me take this opportunity to speak to why this is very important. What has been established is that in individuals, I'll use TB meningitis as an example. When you administer TB drugs orally, the bioavailability of the TB drugs is only 70%. And CNS penetration is only 10 to 30% at a dose of 10 milligrams to 12 milligrams. So already in an individual with disseminated TB, like TB meningitis, if you administer your TB drugs, and these individuals are likely to be unconscious. And what will happen is that the TB drugs will be administered via NG2, and they will need to be mixed. And with that approach, the potency, efficacy of drugs starts to be reduced. And what am I bringing up here? There are some studies that have started pointing out that IV rifampicin or IV TB drugs, they are available, by the way, could be administered in individuals with TB meningitis, TB sepsis in the early phases, and this in itself can accelerate the response. The other aspects also is that I think we need to bring in the functional status of the patient before we start TB treatment alongside ART. Most times we do not include the functional status of the patient. An individual who is moribund, you may want to be very cautious and careful when starting the two drugs together. This is where I'm talking about the tailor-made approach. So you better maybe start with the ATT for 2 weeks, and after 2 weeks, you start the ART treatment. It's very, very important to look at the patient before when bringing in this intervention. Fourth, frontline healthcare workers lack the necessary skills to recognize TB sepsis and disseminated TB. As you see, it's only being picked up at tertiary level hospitals where they are specialists. So we need to build and start to target the frontline healthcare workers at all levels and build the necessary skills to ensure that they are able to recognize these advanced forms of TB. Fifth, delayed diagnosis, unconventional health-seeking behavior, and low index of suspicion, especially for EPTB, is also contributing heavily to mortality, as you saw individuals taking herbal medication, and the like. Slide for a moment. So this is an insight that we pick up, and the findings, dear colleagues, are programmatic as well as clinical implications. And the programmatic and of clinical implications are as follows. The promotion of multidisciplinary approaches in the management of TB, especially for the complicated, is of paramount importance, or rather I would say quintessential. So the TB program needs to start to promote a multidisciplinary approach. And here I would like to, if you saw the patients that died of in-organ damage, let's pick renal failure, for instance. If you start TB treatment in a patient with a comorbid condition such as renal failure, they will end up dying if they are not dialyzed. So you need to bring in your colleagues from renal units to do their part while you do the part of managing the TB. So essentially, we cannot overemphasize the need for multidisciplinary approach and taking a more comprehensive and a clinical approach, enhanced clinical approach to TB management. Then tracking and classification of TB mortality needs to be made routine. The TB programs, I think to a very large extent, do not track mortalities. And what I mean is that the mortality review meetings are not held routinely. So this needs to be made routine and institutionalized within the TB program, because undertaking a TB mortality study is not cheap, by the way. It's resource intensive. But if you put it within the resource, institutionalize it within the routine setup, you're likely to undertake this, and it will inform the TB program more timely. Thirdly, the study highlights the impact of close relatives. The close relatives must be part of the management plan and should be brought much closer. And the program therefore needs to optimize their involvement. So let's recognize that they are an important stakeholder and optimize their involvement. Fourth, the TB program needs to augment the supervision of community-based volunteers to enhance service delivery at community level. You see that family members are doing far much better as opposed to individual or patients supported by community-based volunteers. This in itself starts to signify some gaps in the supervision of community-based volunteers. Fifth is, alongside the investment in biomedical approaches, investment in raising awareness is highly required. You saw an alert mother who recognized TB and took action. You saw individuals failing to take HIV tests and end up dying from TB. So for us to modify and create demand, modify health-seeking behavior and create demand, awareness raising needs to be amplified and needs to continue on. Sixth, as you saw, we had individuals dying from TB sequelae. So the program needs to start to paying attention to PTLD, which is post-TB lung disease. Others call it TB disability. Seventh, the program working with the clinical team will have to evaluate the means of preventing illness and evaluate the evidence of the use of IV rifampicin in special cases such as TB sepsis, TBM to prevent mortality. So this is a consideration by the TB program alongside the four fixed drug combinations. Let's look at bringing in IV rifampicin for special cases. Patients who can't take orally, who are moribund. So in those cases, IV medication may be applicable. So in conclusion, we would like to say that the study points out the necessary and enhanced clinical skills, integrated TB care that include comprehensive HIV care and management of TB, septic shock, end organ damage, anemia, TB meningitis, which were found to be among the common causes of death. Further, we would like to say that operational research is imperative to address the nuances of TB treatment outcomes and to develop targeted interventions that can significantly reduce mortality rates among persons receiving TB treatment. And as experts, we would like to say that TB programs and the health sector at large needs to enhance clinical skills alongside the programmatic approaches of the frontline healthcare workers. Just to say that for the TB programs to work effectively, not only reducing mortality, but also in case finding, the clinical experts need to work together with the TB programs. So while the TB program is advancing the programmatic approach, there is also equal attention to the clinical aspects. If anything, to a very large extent, TB programming is more clinical. I would say 70% clinical and 30% programmatic. With that, dear colleagues, let me recognize and acknowledge all the individuals who stood first to put up this study. I recognize all the outlisted, including the clinicians from UTH who supported this initiative. And also I'd like to recognize and appreciate the support from USAID through one of the projects that ended, which was implemented by PATH, the Eradicate TB, and also to recognize the efforts by Zambia. And lastly, also to just appreciate the Ministry of Health for allowing this study to be undertaken. And I also wish just to appreciate the facilitators of this platform for inviting me. And on behalf of all the authors of this, we would like to express our sincere gratitude and hope you have learned something from this study. I thank you once again.
Thank you so much, Dr. Lungu. Very, very interesting presentation, focusing on TB mortality. But as you will agree with me that we've actually talked about various facets of TB care, prevention, and treatment in this conversation. And so before we get into the plenary, again, allow me to just invite you to send in your questions on the chat box. We will read them and ask Dr. Lungu and the other subject matter experts to respond to them. I've already seen some of the questions pouring into the chat box, which is very, very, very good. But before we get to that, allow me to just quickly run through the poll questions just to assess if there has been learning, if learning has taken place. I will launch for question number 1. I will launch them in sequence. The first one says, does TB cause sepsis? Does TB cause sepsis? Option A is yes. Option B is no. And option C is I do not know. All right, does TB cause sepsis? Very, very, very interesting questions. I encourage everyone to participate by selecting the best answer. And just as a reminder, we have no way, not even the technical team has a way of telling what answer you chose. And so your responses remain anonymous. All right, so I'll end the poll and share the results. So we have 96% are saying, yes, TB causes sepsis. Yes, TB causes sepsis. 96% say, yes, TB causes sepsis. Let me share the next poll question, and then I'll invite Dr. Lungu to quickly comment on the results.
Yeah, so indeed on the first one, I think we've seen some improvement. Previously, 18% had said no, and 8 had said that do not know. So in total, 26% either said no or did not know. But now we have only seen only 4%. So some learning has taken place.
Yeah.
And just to clarify to those that said no, TB can cause sepsis.
TB can cause sepsis. So yes, TB can cause sepsis.
And then also what we mean by sepsis, this is an individual who has fever, tachycardia,
hypotension.
Yeah, exactly. And you are able to diagnose TB from blood. So you have actually TB bacteremia. And all the signs and all the clinical features of sepsis are there, the ones I mentioned among them.
Right. Thanks, Dr. Lungu. The second poll question has been launched, and it says, should TB treatment be tailor-made to suit clinical presentation? Should TB treatment be tailor-made to suit clinical presentation? Option A is yes. Option B is no. Option C is I do not know. All right. So in the interest of time, again, I will end the poll right about now and share the results.
Yeah, so in the previous, when we did run this poll, 41% either said no or did not know.
Yeah.
But now we have only 22%. So some learning has taken place. So, but I think just to bring out to everyone, TB treatment must be tailor-made to suit a clinical presentation. To a very large extent, the majority of patients who will do very well on 4FTC.
Yeah.
And also the aspects I was just mentioning of how you approach to TB treatment. Some of them may need, of course, while this study did not explore the aspects of nutrition and its implication. But a good proportion of TB patients will require nutritional support. And secondly, the aspects of end organ damage. That needs to be, requires a tailor-made approach and a multidisciplinary approach at the same time. So for you to prevent mortality in a renal failure patient who has TB, some hemodialysis may be indicated. So when it is indicated, it needs to be provided to save that single life.
Right.
And yeah, just to pick that aspect. And then also in individuals who have liver failure, you have to manage the liver failure optimally as well. And you require some experts. So you require some interventions that will address the primary liver insult that patient may have.
Right.
In the aspects of adrenal insufficiency, you will need not only to give the 4-FDCs, but also the mineralocorticoid needs to be given, hydrocortisone needs to be provided alongside the 4-FDC to support these patients. Otherwise, the patients will die from hypoglycemia and hypertension, which characterizes adrenal insufficiency, and also adequate fluid supplements in these individuals is warranted. I think that's what we mean by that aspect. And if you look at the TB guidelines, they meet these aspects. So the TB guidelines, to a very large extent, are tailor-made to manage the stable TB patients. But the unstable patients, the TB guidelines are limited in this aspect. So we need to also emphasize, I know the TB guidelines may include these aspects, but it's less emphasized on. So we need to start to emphasize on for Zambia to achieve a further reduction in TB mortality and achieve the WHO benchmark.
Right. And so the last poll question, and if you were paying attention to Dr. Lungu's last remarks, you would have probably picked it up that he has given the answer already.
And no one said no.
All right. So, you know, already the poll that has come through, everyone is responding to say, yes, we need a multidisciplinary approach to manage tuberculosis. And yes, we agree with you if you've said that we need a multidisciplinary approach. For the first time out of, I don't know, this is 3-4 years doing ECHO, I've gotten 100% on a particular poll and everyone weighted in on the correct answer. So well done to you all. We're very, very happy to see that learning has indeed taken place. Now, in the last 15 minutes of this session, allow us then to just get into a brief plenary to get some discussions in regarding what we have discussed so far. Very interesting conversation. So there's some poll questions. Rather, there are some questions that have come in the chat box. I'll quickly get to some of those. But if you have a question, please go ahead and raise your hand and ask your question so that the experts can respond to those. So one of them is from Dorothy Mukua, who's asking, how do we detect sepsis in TB? Very, very good question. So I'll throw this question to Dr. Chanda, Dr. Chitalo Chanda, one of our experts who's on the call. Dr. Chanda, would you respond to that? Dr. Chanda, you may have struggled to unmute, but we've changed the settings. If you're there, please go ahead. How do we detect sepsis in tuberculosis? All right. Maybe I could ask Dr. Chavala, would you respond to that question on how we would detect sepsis in TB?
Good afternoon. Yeah, I suppose the patient will present with the usual signs of what would be described as a septic picture, their fever, and then they have tachycardia, and increased respiratory rate, and you may have some evidence of some inflammatory marker. I suppose in addition to that, you probably then expect on top of that, they may have, some signs and symptoms that may point to TB, for example, maybe cough, weight loss, or, chronic illness. I think in the presence of those, of that sort of presentation, then I would probably then want to have that clinical suspicion.
Right. Thank you so much, Dr. Chavala. One of the common questions is related to sepsis that we come across when we're in the field is, when we're dealing with urine alarm, is that people will give a diagnosis of sepsis without considering those parameters. And, the NTP had to revise some of that. So something that is interesting is that, is it really possible to find someone who's septic or a child who's septic walking around in the clinic, running around, jumping up and about, just because they had a temperature of 38.5 degrees? We've been given that diagnosis of sepsis to warrant the use of urine sample. So maybe Dr. Lungu, you could comment on that.
Yeah, actually, if you look at the clinical definition of what sepsis is, it's not just one parameter, but a combination of at least three, as Dr. Chavala also pointed out. Pyrexia is one of them. The issues of increased respiratory rate, issues of tachycardia, increased pulse rate, and also the presence of a confirmed or microbiological diagnosis. That in itself is equal to what is sepsis.
Right.
Yeah, so, and this could be by culture. But in the case of TB sepsis will be recognized, of course, in that particular study that I shared. That was actually what they were doing was actually blood cultures. It's a very expensive approach.
Yeah.
In the routine TB programming, but using the clinical symptoms, one can actually derive to say this is TB sepsis, even by the presence of a confirmed gene expert positive and the presence of clinical parameters, hypotension, tachycardia, increased respiratory rate, tachycardia, and all those features being present, one could say they are dealing with TB sepsis.
Right. Great. Thank you so much for that, Dr. Lungu. There's a question on availability of the IV anti-TB drugs like IV rifampicin, IV isoniazid. Are these available in Zambia?
Yeah, of course, I think these are things, if you look at I carefully tackled this aspect that the program must look at the evidence in support of this. Currently, no, but these options are available, and the TB programs must consider, in my own opinion, must start to consider stocking out these options for addressing TB, in particular patients, those with TB meningitis, and the ones who I mentioned are those with TB sepsis. We will need to consider that option. And this is all in an effort to save the lives. And I also mentioned to you that the bioavailability of oral anti-TB medication is at least 70%. And CNS penetration, when administered orally, is only 10 to 30%. So this in itself disadvantages an individual from surviving. And secondly, in individuals who are in a comatose state, we tend to provide the medicine through an NGG, which in itself starts to just destroy the efficacy, the potency of the drug. So by the time the drugs are reaching, their efficacy and potency is heavily reduced. So the individuals may die from TB meningitis, not because that the medicine was not effective, but ineffective because of the mode of treatment that we have used. Already TB meningitis has a mortality rate of over 40%. And we're still, if we use it using orally, the studies which are coming out are showing that when IV rifampicin is administered in TB meningitis, there was an increased survival rate in those individuals.
Very, very interesting findings and insights from publications so far. Let me turn to Dr. Chimzizi from the NTP. Dr. Chimzizi, any comments or highlights that you'd like to share on the presentation and also the findings of the mortality study? I think it was highlighted that you took part in this particular study. Any thoughts to share?
Yeah, thank you so much, Dr. Singini. With me also is the NTP manager. We're using the same computer, Dr. Mwanga. You know, when Dr. Lungu presents, you had to find something that he hasn't touched. I know him by that. So, but I think what I just want to add is related to the same, that most often when a diagnosis of TB is made, probably that's the end of that patient to see a doctor. The patient will never see a doctor again.
Yeah.
And then what happened, probably some of the deaths also, I think we have aside sepsis, sometimes is a poor clinical care. So I was just discussing with the program manager here, probably internally, we really need to have an indicator to measure out of the 6 months the patient is on TB treatment, how many times has he been clinically reviewed so that we can so I think that's what we are looking at. Most of our patients, once they are on TB treatment, it is assumed that the only disease they have
Dr. Chimzizi, we've struggled a little bit to hear you in the last few seconds. But if I got you right, you are emphasizing the need for our TB patients to have regular clinical reviews and that we should introduce an indicator where we track how many times our TB patients are having clinical reviews during the course of the treatment, if it's 6 months for those with drug-susceptible TB. I think that's very, very valuable insight that you've shared. Now, Dr. Chavala, you are a pediatrician. Would like to hear some thoughts on TB mortality, particularly in people under the age of 15 or the pediatric population. Any insights to share or observations that you have made in your clinical practice as well as research outputs?
Thanks. Thank you very much for that. In fact, one of the comments I made was that in this very huge study, thankfully, we had relatively fewer pediatric mortalities, you know, which kind of goes against the conventional wisdom where we usually see that usually if you compare mortality in children, it's actually for the proportion of deaths from TB in children is usually higher than in adults. But I think the issue here could be that really that's not the case within our locality, or there's always this issue that we're missing those children who die from other things, pneumonia, malnutrition and all those other things, where we have noticed that if you really look for cases in those groups that come with other clinical, that present with other features, such as severe malnutrition, pneumonia, that you may actually, find it. But yeah, from that angle, this study does provide some reassurance that there wasn't so much mortality. But I think we should also have that caution that probably that maybe this is against the background that we are very, few pediatric diagnoses, and the ones that we should be looking out there, especially the ones that get hospitalized, might be under the radar.
Right. Thank you. Thank you so much, Dr. Chavala, for sharing the thoughts regarding the pediatric population. Now, as we wrap up our presentation and session for today, let me just quickly invite the NTP manager, Dr. Mvanga, if there are any few remarks from the program's perspective regarding dealing with mortalities in Zambia that you are recommending.
Thank you so much, Dr. Singini. And indeed, Dr. Lungu, a very, very great presentation, and we are happy that you are around. We couldn't just let you pass through with this good research finding that you are done with a team. And indeed, you've highlighted very, very critical things in this presentation, which I think as a program we need to take seriously and work with the experts in various areas, especially our clinical side, both the pediatricians and also the senior consultants in all the departments, to see how we come to an end, we bring to an end these high mortalities. And indeed, it's not like just a coincidence that this research brought out these key findings, but it's just what we are witnessing day by day and year by year. We are noticing that we are losing quite a number of patients from our tertiary institution, and having a detailed discussion recently gives us as a program an opportunity to probably look at some critical areas that we need to revise in. And in this area, I think it's important, as my colleague Dr. Chimuziro thrown out at one point, he was trying to make a point on the issue of using targeted approach, where we need to actually implement QI, even facilities to just try some of these key findings that Dr. Lungu you have highlighted. Otherwise, to the teams on front, there is more work to be done in the TB space. It's no longer the work of one highlighted. A multidisciplinary approach is the way to go, and we bring on board to bring on areas at level. We've seen the role of, I think, relatives there, how important they are. So it's not only coming from the clinical area, but also from the community side. Let it be a full cascade so to can actually end TB by 2030. Otherwise, Dr. Lungu and the team, I'm so impressed and looking forward to some of the initiatives that we need to make.
Thank you so much, Dr. Mvanga, and all the other experts that have joined us. It's been refreshing having this conversation on the TB mortality findings from the research that was done on 2019 data. We just have a minute, so I'll ask Dr. Lungu to just close with a summary of the presentation, and just to mention that we'll share this slide as well as access to the study that was done through the iEcho platform. You will be able to read extensively the paper. Dr. Lungu.
Yeah, thank you so much. There's one question I think perhaps I may need just to address. There's one question about the Kaplan-Meier, and also a suggestion that we should have actually stratified by HIV status and various other variables. So just to indicate that we did actually stratify by HIV status, type of TB, and actually the Kaplan-Meier became even more informative, even by levels of facilities. So if you look through the paper, I was looking at means I would have shared that. Unfortunately, there are too many slides, so I missed out that aspect. But indeed, when we stratified by HIV status, ART, and also by province, we actually found out more information as which type of patients are even dying much earlier. And indeed, of course, people co-infected with HIV were dying much earlier as opposed to the HIV negative individuals. So we did explore that. So thank you so much to the program once again, and I'm happy that you have well received the presentation. And also just to underscore that Zambia is actually doing very well with regard to the TB response. However, I think the aspects of mortality and the response towards reducing mortality needs to be enhanced. As if you do recall in the previous NSP that ended, it was powered to reduce mortality. So probably maybe within this aspect, find ways of amplifying on quality of care. And I'm happy that the program manager pointed out the issues of quality improvement. That in itself can actually reduce mortality. And again, colleagues, clinicians who are on the platform, join hands with the program in order to reduce TB-related mortality. I thank you, dear colleagues, for listening, and thank you to you, Singini, for hosting me. Thank you.
Thank you so much, Dr. Lungu. Just reminders to the network that we are still in campaign mode to strengthen active case finding for tuberculosis. We learned from the presentation today that early diagnosis is a key driver for good treatment outcomes and preventing death. So please join us as we find the TB cases around the country by conducting active case finding at our respective facilities. So with that said, thank you so much for joining the call today. Looking forward to meeting you on the next session. Bye and God bless.
Delivers